Hello and welcome to our Insight to Healthcare webcast. Delighted today to have a new topic and some new panelists, which is always really exciting for those of you that have seen some of our previous webcasts. And today's topic is that terrifying, spooky topic. No, not Halloween. No. This is winter pressures. We are looking at predicting the unpredictable, navigating those winter pressures with hidden insights in primary care. I've got a fantastic panel joining me today to help us on that. I'm not going to introduce them. I'm going to ask them to introduce themselves. And I'll also, as I always do, ask them a question when I do that. And talking of questions, before I do introduce them, if you have a question, if you have a comment, please have a look in the comment section. That's if you're watching this live. Fill in your comments, fill in your questions. Let's create a conversation, because that's what these webcasts are all about. So the first of my panelists today, I'll actually go with Paul. Paul Friend is a healthcare improvement specialist. I'm going to let him introduce himself for the next 30 seconds, but I'm also going to ask him one question to start off. If you're watching this live, it's the 31st of October. Told you it's Halloween. Is it too late to worry about winter pressures? Paul, introduce yourself.
Cheers, Darren. So I'm Paul Friend, healthcare improvement consultant specialist. I work on the GPIP program, and when I'm not doing that, I work in social care as a program manager. I've worked in healthcare quite a long time now, but previous experience as a practice and federation manager and director. Is it too late to tackle winter pressures and start making plans? Absolutely not. There's tons that we can be doing right now. If we've not had those conversations in teams about what our contingencies are, identifying patients that previously we might expect to put a higher demand on the service and put plans in place to deal with those people effectively, which might be things like rescue meds or other people that can reach out to those sort of care planning sort of patients that we can actually make a greater effort to sort of tackle ahead of time. Then there's lots that we can be doing now. But I think particularly it's having this conversation in practice is about what our sort of red, amber, green states are and what do we do when those arrive. So there's lots that we could be doing in the next couple of weeks to actually really make an impact when those things start to hit, as they inevitably will through the next 3 or 4 months. So
thanks, Paul. That's great. Selena, I'm going to ask you to introduce yourself next. 30 seconds about yourself. And also, if you can answer that question, is it too late on the 31st of October to be worrying about winter pressures? Have we missed the boat?
Hi, I'm Selena Dobbs, practice manager and PCN manager for Newgate Medical Group in Bassett Law. I've worked for the practice for just short of 30 years, but been practice manager for just 3.5 of those years. Absolutely not too late to be planning, discussing with your teams, looking at where the bottlenecks are within the individual teams, communicating out into the public what they can do for self-care, the Pharmacy First programs, how they can access the right care at the right place at the right time.
Thank you, Selena. And Saj, lastly to you, same, introduce yourself. I'm going to tweak the question just to trick you. When is too late? You're on mute, Saj.
Hi, everybody. Hi, my name is Sajid Khan, and I work for Develop Consulting within the healthcare sector and provide support for practices up and down the country nationally as part of the General Practice Improvement Program. And again, I've been supporting general practice for the past 10 years or so. So I have a rough idea of what goes on in practices. And I think, as you mentioned, Darren, as winter approaches, general practices across the UK are kind of bracing for that annual surge in demand, with winter pressures significantly impacting primary care. And we know because of the increased cases of flu, things like respiratory infections and seasonal illness, this period after kind of sees a spike in patient visits, which put, again, immense strain on GP practices and healthcare staff. And the challenges are compounded by sometimes workforce shortages or other ongoing needs to manage some chronic conditions alongside the acute illnesses. So again, I guess today when we explore how practices are preparing and planning for some of these strategies, or planning some of these strategies to help implement and cope with this plan. It'll be really interesting to understand from the panel today as well, and kind of listen into what is the impact of these realities on primary care. And I guess to answer that question of, is it too late? No, I don't think it's even until, this is the beginning of that kind of area. And even though we're on the 31st of October, and we're coming into, November or December, sometimes winter can last all the way through to sort of, mid to late January and early February even. So I think now is a crucial time, I guess. It's rather than an early or late, I think it's a crucial time to really sort of finalize some of those preparations for winter pressures. And I think as many practices start, or although some of them have already sort of started well in advance, late October is still a good time. All measures are in place to make sure that any necessary kind of adjustments can be made based on some of the conversations even we have today. I think there might be some learning out of today that people can go away and implement in their practices over the next coming days and weeks.
Absolutely. And by the way, you've given some really great news, because if you're not watching it live today on Halloween and you're watching it in a couple of weeks' time, it's still not too late. That's the message that we're putting out there. Selena, if I can come to you next. You're a practice manager. You're also with a PCN. Do you see any standard approaches that you take to manage and predict that winter demand?
Well, we're quite unique as a PCN. We're a single practice PCN. So obviously we've got the disadvantage of not having the other practices to discuss and look at standardizing approaches. We've got our own approach. So I guess that's fairly unique, but we do work very collaboratively with our neighbouring PCN. And actually, about 3 years ago, we set up an ARI, acute respiratory infection hub, collaboratively between us, specifically around this time of year to look at the pressures on GP practices. And this is where we put in a locum GP, and both practices could feed into specifically around the acute respiratory infections. We know it hits us hard this year, and we know standard GP capacity struggles. We also know, and we've seen specifically at this time of year, children come home from school, and it's then that you get the increased volume of calls, 3 p.m. in an afternoon, and that's where the demand is. So again, deliberately, the ARI hub is operational up until 6 o'clock in an evening, so that the GP practice can continue with the capacity and demand during the day, and the ARI hub can support those patients needing appointments or clinical input later on in the day. We've found that to be really beneficial over the years.
And Selena, linking this back to the previous question, is it too late to set up one of these hubs if you haven't already? How long does that take?
Absolutely not. I mean, if you were to do it as an individual practice, then no, it's really easy to do. I guess collaboratively, it takes some time to work between PCNs and get your agreements set up. But no, you could do it in-house as a practice, look to see if funds are there and how you could pull funds from certain aspects and provide a locum service or a GP specifically dedicated, or even use our staffs within the PCNs. We've spent a lot of time over the year mentoring our ours additional roles reimbursable staff for the PCN to be able to support under 16s, because we know this is where the demand can be, especially in an evening, but also looking at the acute ears, eyes, nose, throats, chest infections, so that they can take the demand, the capacity demand, and then the GPs almost become the consultants. So they're looking at the chronic illnesses, and it helps keep the turnover, supporting both aspects during this winter time.
That's really great, Selena. Paul, if I can come to you, you're working across lots of practices. What are you seeing that's a standard approach that people are doing that might be a great tip to put out today to get people motivated and moving?
There's a lot of the regular things that people have been doing, such as looking back at historical data, looking at when they had the issues around absence, looking at the if you've got access to it, telephony data, looking at your hotspots, particularly looking at patients whose attendances did increase through winter last year, and they'll probably be in sort of respiratory groups, as Selena said. I really like that idea as well, Selena, and I wonder if it's possible to maybe sort of take advantage of the systems you've got in place for PCNs, where you've got practices that are working together to be able to use some of the extended, the enhanced access sort of facilities to sort of share that. So if you kind of all put in a little bit of resource into kind of spreading the load there, I think that's a really good idea. And that's not what I'd seen elsewhere, actually, so that's fab. But particularly identifying your records for the patients that are at risk on respiratory, to make sure they understand their own self-care plans, as we mentioned, but also that they've got things in place around the rescue medication and things like that. And looking to identify groups perhaps where you're getting missed appointments and things like that, and to actually reach out to those, because obviously that provides an even bigger impact at this time of year. Obviously, I've said before, contingency planning, making sure that you've got that cover in place, that understanding before it happens that somebody's going to maybe step up. It might be working with your partners to understand that what's going to happen if you've got a bit of a gap, who's going to fill that space, and how's that dealt with, whether it's financially or time back and things like that. But you've got that agreement before it happens, so you're not under pressure when it does go down. Something that actually doing with a practice sort of more recently, and I've covered elsewhere, but I think it's really important doing the partnership working, particularly with pharmacies and other kind of services like that, sort of frontline stuff. But currently, I'm actually just doing a little bit of work with a practice working with a pharmacy who's very keen on pharmacy first, and they're actually starting to give access to their clinical system to a pharmacist on an honorary contract basis. So it can just help make the effectivity of the consultation of the pharmacy that little bit sort of more acute for them, and make it a quicker turnaround, but reduce the burden on the practice with that coming back, sort of, that sometimes does occur if there's sort of missing information in the referral. So it's not maybe something everybody can do, but if you've got a friendly sort of dedicated pharmacist you've got some trust in, you can go a little bit further, actually work collaboratively to kind of spread that load and actually hopefully benefiting everybody, patient, practice, and the pharmacy in doing that.
Thanks, Paul. Saj, coming to you, similar along the same lines. Are you seeing any standard approaches in particular to that predicting the winter pressures? I've heard a lot over the years of, well, we can predict it or we can't predict it. It's different every year. It's the same every year. I hear a lot of noise around it. Are you seeing any particular techniques that really work at that prediction?
I guess the thing here is that primary care systems and practices are kind of aware of some of those seasonal challenges. And they do kind of come in cycles, right? So year on year, they kind of have similar approaches. The volume and scale might be slightly different, but I think in terms of the things that happen, are kind of regular. So if you think about the demand perspective, the types of demand that we're probably going to see, is chronic conditions. So we're talking about exacerbation of chronic illnesses, asthma, COPD. We mentioned earlier on about heart disease and respiratory diseases, but some of the other things and then you got a seasonal, so you got flu and those kind of things that are going to happen. But then you've also got things like mental health. We know how seasonal affective disorders kind of come in place, where short days, reduced sunlight, and some of these kind of things really affect patients. And it's understanding that patient profile and the type of patients that we have, that how do these, or how likely are they to be affected by some of these, and also thinking about holiday season, right? So coming up to Christmas, the challenges around stress, anxiety, the holiday season can bring about increased stress and worriness about, have we got the right things, economy wise, financially, all these other burden and pressures can really impact upon that patient profile. And depending on your practice, if it's in an affluent area, non so affluent, etc., it can have a real impact upon your patient profile. So it's really good to kind of consider and think about what is our patient profile and what do they look like, and what are some of the challenges that we perceive can happen. And some of that might be worth looking historically at data that already exists within the clinical systems from last year or the year before, such as Paul mentioned. But then it's thinking about going forward, what is it looking ahead that we can actually manage, which is within our capacity, around things like staff shortages or the right individuals, because it might not, like I mentioned before, we might not need all GPs. We might need more mental health nurses, more social prescribers, more other roles, like Selina mentioned about developing them in under 16s or over, 40s, etc., or those kind of things. Looking at how do we build those kind of skills up within that profile, that skill profile within those staff, and then looking at other kind of we're all aware of kind of the funding issues around capacity to be able to hire more or less, or like you said, overtime or extended hours, etc., to impact upon some of that.
Thanks, Saj. Saj, Selena, Saj mentioned staff there and staffing issues. Other than the sort of health issues, are there any common issues? Is it short staffing? Is it what is it that you see that's common every year that seems to be an issue to you and that hurts primary care?
Yeah, I mean, obviously the illnesses that affect our patients also affect our staff, be that clinical or administrative. And at any one point that can have a real impact on the service provision. So it's about planning that. And plus, obviously, it's holiday season for staff as well as patients. So it's about planning annual leave as well. Something that we did many years ago was look at changing our staff leave year. Instead of being January to December, to be, say, birthday to birthday or start date as an anniversary, so that it spreads the burden across the year for staff leave, and you don't end up with everyone in every department trying to get their annual leave in before the 1st of January, and therefore having a reduced structure at this pressured time. But it's also about making sure that you are supporting your staff, and the increased demand at this time can affect their well-being, their resilience, how they cope. And if you've got that underpinning with your staff, regular weekly meetings, mentor one-to-one sessions, group meetings where they can be involved in the decision making, we found certainly through GPIP programme, close working with Paul, that if you involve staff in the decision making, they become invested in the service that they're providing, and they also then feel heard and supported, which again makes the service far more resilient.
That's great. Paul, coming to you again. You're working on the GPIP program. By the way, if people aren't doing the GPIP program, you should be. It really makes a difference. When you're on the GPIP program, are you seeing any common issues? So I'm not talking about health issues or just general demand. Are you seeing any common issues that you see time and time again that are points of failure or points of stress within primary care to do with the winter pressures?
Yeah, I mean, definitely things that are always there, but things that get exacerbated this time of year, particularly around pinch points, as kind of Selena's mentioned, that around that certain days of the week, obviously Monday mornings and sort of late Fridays and things like that, where you're getting particularly hit. And something that's useful to look at, even if you're not a fully sort of online practice, but as Selena can attest to, that actually moving some of that non-urgent demand to online processing, so you're not actually having people compete with each other to try and get through the telephone at a particular time of day, can make a huge difference. It also means that you've got a kind of more equitable assessment for handling incoming requests, particularly for things that are non-clinical that can be moved to an admin task. And it takes the heat off the telephones, and that's can be really difficult if there's sort of particular flow outbreaks in an area and things like that, and people can be calling in sometimes prospectively as well if they're concerned about sort of particularly younger people or older people, and just being able to move some of that impact off the hot points of the day can be really helpful. Again, you'll find that particularly when people are quite poorly with acute stuff, the DNA rate can increase. So looking to sort of put some effort into kind of communicating with patients about how important it is to cancel and making that easy for somebody to do. I think Selena's practice did put some quite sort of wise precautions in about just having a telephone line with an answer machine in place for people that don't have easy online access to cancel appointments. And as Selena says, that it does put an awful lot of pressure on staff, and looking to make sure you talk to people regularly and pick up on those things, because things that you might not see in data might be incredibly evident for your frontline reception admin team members. So speaking to those people, that they'll be seeing things and sharing those when they're a concern before it actually becomes it's got a full-blown crisis in the practice.
Thanks, Paul. Saj, again, you're highly active in the GP improvement program and other things in primary care. So you're seeing multiple practices. Again, are you seeing any common issues that we haven't touched on that would you see time and time again repeating?
I think one of the kind of key things that kind of comes to mind at the moment is as we get to winter pressures and some of the challenges, there's a real kind of focus on treating a illness, treating a condition. So, for example, respiratory or asthma or COPD. But generally what we find is our patients have multiple, issues and multiple conditions. And sometimes trying to focus on just a condition, one item at a time in a consultation might not necessarily be the best way to support patients. And so I think something more around developing or delivering more comprehensive care around actually the individual themselves and all their conditions, and thinking about what is the best care for that patient at that particular time with all the comorbidities and challenges may be a little proactive way of trying to help personalize some of that care for those individuals to make it a bit more efficient in the time frame. So appointments might be a little bit longer, and I appreciate that goes against some of the things that we're talking about, but it may reduce the number of times that patient may need to come back into the practice again and again.
Thanks for that, Saj. And by the way, thanks for Steve and Callum. We've got people commenting in the private chat. A lot of comments there about staff, which I'm going to come to. Really, we're going to measure on in the second half hour of this webinar. Before we come to that, let's grab a nugget. Let's spend the next 9 minutes talking about a nugget. What are you recommending, or what are you going to do? And I'll start with Selena on this again. What's the one thing you're going to do different this year?
We have massively increased our digital and social inclusion for our patients. So making accessibility greater. We've got, as part of our PCN, we've got a digital and social inclusion coordinator who's been holding workshops and sitting in waiting rooms, pushing the NHS app and the ease of use so that patients can access their test results. They can cancel appointments to reduce the DNA rate. They can book their own appointments online when they're at work at any point of time during the day at their convenience. They can source multiple advice on there as to self-care, how the pharmacy can support them, supporting the pharmacy first work. So really widening the approach for patients, which in turn will hopefully support a reduce in the demand on GP primary care.
Great, thank you for that. Saj, what are you seeing done different? Are you seeing anything exciting that somebody's really going to change this year? I
think Selena kind of touched on some of these, but there's a couple of things. So first of all, from a proactive management and planning and replanning, I guess, there's something about, enhanced access schemes. So it's understanding how practices are extending their hours, offering weekends to hopefully try to manage some of these kind of peaks in demand. There's also the use of now kind of virtual consultations and trying to not get people coming into the practices or spreading some of these kind of issues and viruses, etc., but more trying to manage them and conduct some of those kind of routine checkups and that kind of more proactive care with individuals that we predict may be more kind of frequent attenders, is maybe utilizing, kind of telehealth, virtual consultations, etc., to be able to proactively manage them rather than spending time to going out to them. Could we use some of those to be able to reduce the time it takes to consult that particular patient? Also, I think another big demand that kind of impacts practices at this time of the year, care homes. And I think, really proactively putting some dedicated teams to be able to manage the care homes to help divert some of that work away from general practice, maybe a really good, focus area to do on as well. And then coming into technology, like we talked about, improved telephony data. And I think this is where the general practice improvement program really comes into its own, where helping practices that are on their journey to either enhance or further move into their kind of model of modern general practice, where we're utilizing telephony and telephony systems more effectively, understanding and managing and monitoring their real-time data more effectively. And then, like Selena said, using collaborative approaches with local services and pharmacies and other practices within the region area to be able to help within their PCN, to be able to put services in place that are really help manage and focus on the community needs or the population needs that they serve, are really kind of proactive ways of helping managing some of these challenges around winter.
Saj, just before I come to Paul, you started your answer there Very comprehensive and good answer, by the way. You started to answer that with, we've got practices working weekends and extending hours. How can this not just be about working harder and battering our staff, be they clinical or administrative? The latter part seemed to be about working smarter. How can we make people not instantly think the only way to deal with winter pressures is to work longer and harder?
So this comes on to that third point, Darren, which is more about that self-directed care management and actually really putting some good campaigns out there to help patients understand and educate themselves and on managing some of their conditions, which doesn't need to happen now, but needs to happen, all the way throughout the year, really, to help the clinicians to be able to utilize that time that they have with those patients, effectively. And this is where some of the things around understanding pre-consultation information and how effective that is, and our kind of triage and care nav processes and systems are really helps. So when that GP or clinician is with that patient for those 10 minutes, how are we really effectively maximizing those 10 minutes to make sure that they're utilizing that time as effectively as they can, rather than repetitively asking some of the similar questions that should have been asked, or the data should have been captured, or they should have had that available to them before that consultation. So there's something about how can we utilize that patient education piece. Second bit is those kind of supportive kind of interventions. So providing self-management support through education, goal setting, regular follow-ups, moving from a reactive care model to more of a proactive kind of care model. Thinking about some of those kind of areas and how we can support patients to be able to really manage some of that care themselves.
Thanks, Saj. Paul, over to you. Going back to that original question of, are you seeing anything really innovative, a bit different that people or lots of people or just one practice is going to do this year that's going to make a difference?
So two things that I've seen that have been really important. That one is people that sort of managers spending time with the reception teams and the care navigation teams to really make sure the plan that's in place for how people are care navigated and triaged within the practice is happening sort of consistently through the practice. So not just kind of setting it out as a protocol, but actually making sure that's lived and that's what's actually taking place, and consistently doing that as well, and making sure that's effective across the whole team. And where it's not working, identifying what's wrong in the system to support the people to deliver that care that's been asked for. The other one is a lot of, and I've kind of mentioned it before, but really reaching out with partnerships, particularly around the teams that are going to be dealing with people that are acutely exacerbating over winter, which are going to be the pharmacies, the respiratory teams, the diabetes teams, sort of frailty teams, really making sure that everybody's got a really clear understanding about who their patients they've got concerns with are, and that they're being acted on proactively and not waiting for it to become a problem for somebody that might actually have sort of further problems later in the winter. So, and aside from that, make sure everybody's got the flu done. But it's, and I think picking up on some of the things that Saj and Selena have said around, I really like the stuff around the social inclusion, the digital inclusion work. That's fantastic. And I'm glad you're getting support for that. And again, some of the stuff that Saj just said, just around sort of care navigation and just kind of bringing the team with you to make sure that you're delivering the care that you hope for, I think is incredibly important. But you've got to make sure that you're picking up on those things within the practice before they become a problem. And that means you've got to be speaking to people and keeping on your toes, and probably sort of regularly having sort of full practice sort of touch points. You won't be able to do it with everybody at the same time, but actually just setting up regular touch points so somebody can kind of input and just kind of share their experiences throughout the winter. Because if you let some of these things go unsaid, you'll not be able to fix it in time to actually make some change, some difference for it throughout that season.
Thanks, Paul. Paul, just you're delivering the GP improvement program, the NHS England program, to lots of practices. I think there's now thousands have done it. Do you find, particularly the ones that you've done over the summer, so you're just finishing up now, are they going into this winter season with more confidence, having done that, feeling they've got more grip on what they're doing?
Yeah, definitely. I think there's we obviously try to instill quality improvement throughout the practice and making sure that people are dealing with things in a proactive and planned way. And that means bringing everybody in the practice along. So identifying what the issues are, and then using a method where you're identifying the issue, making sure the thing you actually think is the problem is actually the problem. We're quite good in general practice at reacting to something and a little bit of evidence sometimes, and that does need, whether it's just a snapshot, sort of 5-by-8 sort of a tally chart, or whether it's a full audit of what we think is actually occurring in the practice, but making sure we're dealing with that scientifically. We bring in a measured approach to make a change, and then we evaluate that change to make sure the change we're hoping to get has actually been delivered. And putting that in place within a practice throughout, the comparatively easier times across summer does mean that when things become more critical, when there's that greater burden on the practice, it gets a lot easier to actually deliver a change and make sure the thing that you're hoping to affect is delivered. If you're using that quality improvement methodology, sort of using lean techniques to make sure that we're not wasting resource, and making sure that we're getting the best common approach for the work that we're doing across the whole improvement plan.
Thanks, Paul. As promised, as we get into the second half, by the way, I will be coming to your comments online. Please keep feeding them if you're watching this live. As promised, I just want to talk about staff in this second half quite a lot. We can look at demand. We can try and second guess it. We can look at historical data, and I know, Saj, later on you'll get your opportunity to talk about the demand and capacity optimization tool. But let's talk about that capacity bit. Is really about staff. How are we going to keep our staff healthy, motivated, innovative, and engaged during this coming winter? What are you seeing? What are we doing? What do we need to be doing? Selena, can I come to you on that first?
Yeah, I think increased visibility from the management team for all administrative and clinical support staff. Staff need to feel that they can come up with suggestions and ideas, and if you make yourself from a management position easily available and approachable, then you can quickly implement anything that would support an individual team. But it's also about considering their well-being. There's so many well-being packages and support packages for the staff. It's making sure and reminding them of what is available. It's also about little treats, selection box for your staff at Christmas. Costs very little, but means an awful lot to your staff, especially if it's given out by the practice manager or given out by a partner. It's that personal touch. Maybe a Christmas party for staff, something that, they can feel that they can achieve to. Little rewards, silly incentives, somebody once suggested to me a Golden Duck Award, something that you can sort of say, I've given Sarah the Golden Duck Award because she gave the best care to an elderly patient. So keeping that focus, family GP approach when the pandemic has forced everybody into social media, less face-to-face contact, but it's about trying to keep that family GP approach open, specifically for our elderly, more isolated cohorts, because that one contact that they might make is so important to them. That, and it takes an awful lot for an elderly person to contact you and say that they're needing support and help. So the staff need to be in a position to be able to offer that support immediately.
Great. Thanks, Selena. Saj, are you seeing anything innovative around the staff in particular? Because that's who's watching this, let's be honest. How can we help them?
So I guess, the first point there is, winter pressures significantly impact practice staff, right? Let's not, what affects our patients affects our staff as well. And I think, the leading increasing workloads, longer hours because we're extending, high stress levels, all these kind of things sometimes can result in burnout or reduced job satisfaction, or even some of the challenges of sickness, etc., that we see at that time, which then again reduces capacity, which increases pressure. So it's kind of like a really kind of vicious cycle. But, and like I mentioned before about some of the mental health disorders or the kind of holiday season kind of anxiety and stress and financial challenges also affect our staff. So we've got to be mindful of all of this when trying to provide a service that services our patients that we think are going to expect these kind of challenges and issues as well. So I think there's something about understanding how can we be more or provide a more flexible staffing model. And this is about understanding, adjusting the staffing levels, not necessarily as we do that. If people come in at 9, they've got to stay till this particular time. But actually, does our staffing level mirror our demand peaks, and how can we support people coming in at those particular times? And be a bit more flexible during this kind of holiday season, and understanding how do we manage the right roles and availability of individuals at these times. So, if somebody works during the morning till 1 o'clock, I'm making an example, a clinician or nurse, whoever, but then we realize that after 3 o'clock, we've got peaks of school children coming in because of issues. Well, actually, that doesn't necessarily work. So it's thinking about, well, actually, how do we move that or manage that capacity slightly differently? Working with the staff to be able to put a plan in place that helps manage some of those peaks that we talked about earlier. And the other thing is like Selena mentioned, there's plenty of well-being initiatives, but we need to utilize those well-being initiatives. We need to put them at the forefront, communicate them, have boards, have initiatives, have weekly sessions, taking some of those time out, during busy periods to take a 15-minute get together or a half an hour in the kitchen or a bit of a conversation. It's about building that culture and helping staff support themselves, and that resilience that is really important within practices. And it's sometimes can be quite a closed environment, and they get quite a lot of abuse and everything else, as we know, for patients. So it's understanding where can they go and take that and dump that somewhere where they can then come back and be nice or fresh again. So it's thinking about some of those kind of initiatives that support staff well-being. And I think some of those strategies highlight the importance of, I guess, proactive planning. We talked about it's not too late, but we still got time to do some of this thing, where sometimes the use of innovative technologies or the collaboration efforts to manage this increased pressure, really, especially during these winter months, can help both focus on patient self-management and staff support. Sometimes we kind of leave the staff support bit. It's not as focused in some of the patient management that we focus on. So I think by doing that and better navigating the challenges that we face and understanding some of these, we're able to plan a bit better, which hopefully will reduce some of the challenges that practices have going forward.
Thanks, Naj, and thank you to Nana online, who's liking the idea of Christmas meal and awards, really helping bring staff together. Paul, on this very subject still, are you seeing anything really good? Are you seeing that difference? Because to me, primary care's a team sport, and as with any top sports team, if you look after your athletes, you end up winning the league. Are you seeing anything really different in any particular practice that you've gone, wow, that's a great example and everybody should be doing it?
Yeah, I've seen a couple of practices now where they're looking at the hotspots around patient contact, whether it's admin reception or whether it's the doctor on call, the real sort of front end of what can be particularly sort of mentally demanding, and looking at adjusting the shifts over winter. What might be quite tolerable to do for a period of time in June can be incredibly hard to do the same level of time sort of committed to a shift, on whether it's on call or whether it's just answering the telephone on reception. As you say, it can be very challenging such to stay on the call for a long period of time. So looking to alter the working patterns to just reflect that taking some time away from that for a period can be beneficial for everybody, sort of for well-being, in terms of effectivity of doing that as well. Everybody performs differently. If you've done that same thing for 8 hours a day, that it's when you can't keep at max for so long. So just sharing that load between your colleagues might not affect what you do over a week, but actually just the concentrated time doing that, taking some time to have a bit of a breather, where even if it's just for an hour that somebody takes over that duty role, or whether you're splitting that shift weight, it might previously be something that you did for a full day, that you split it with a colleague and agree to do halves on that. And for reception to actually, for the admin to actually move across either being on the front desk, but particularly being on the telephones when you're in a high demand. Monday in a GP practice during sort of flu season is incredibly demanding, and looking to just kind of vary the task that people are doing, because not everybody's doing that front end task all of the time, and giving them a bit of an opportunity to just step away from that and have a decompress can be really beneficial. And I've seen a few practices that are looking to sort of make a few changes around that.
Thanks for that, Paul. Saj, along a similar theme, I don't want to go back to a previous webcast we did, by the way, you should look at it, on failure demand, but is there sort of added pressure on the staff if we don't do the signposting correct, i.e. they're trying to deal with something they shouldn't be dealing with in the first place. It's somebody else's job to deal with. So if we get that right, does that relieve the pressure? Also, getting it right first time reduces the demand, doesn't it? Is that something we should be looking at to help with the winter pressures?
I think definitely. I think helping staff, and this is where clinicians can really come into their own then by understanding that patient profile, like we talked about earlier, understanding some of the challenges of the type of patients that are appropriate or inappropriate. This is where, and like Selena mentioned about the oval of flow hubs, being able to navigate appropriately and effectively, both internally, i.e. to the different levels and different roles and different clinical roles and availability that you have within the practice, is so important to make sure that the right individual is being seen by the right clinician for the condition. But likewise, if we have, and are we, is a question really, as a practice, maximizing the services that are available externally? So are we signposting effectively to other services that we think are available or that have been commissioned within our local area? And are we utilizing them effectively? And then I guess another question on top of that is, how effective are those external services? And when we do signpost patients to those services, are they really being dealt with, or are they having to come back in to us again, which can sometimes increase some of the demand? But I think being able to educate the care navigation staff to be able to understand that and be clear about where it's appropriate to internally navigate to the right individuals or externally, I think is really imperative to be able to help ensure the right patients are being seen by the right clinician, and as Selena said, at the right time.
Thank you for that, Saj. Selena, are you seeing somehow or other empowering the patients as well with better self-care management, whatever, is helping reduce winter pressures and helping your staff?
Absolutely. Something that we've started to introduce in greater volumes this year is patient care plans. So those patients that we know have chronic disorders that will be specifically affected during winter, for their own registered GP that they're familiar with, that they would want to see if they were ill, but obviously due to the demand may not be able to have an agreed care plan in place on their medical records that they have discussed with and agreed to with that GP or trusted clinician that they've got, is really helpful. They understand what is expected of them at certain points of their condition and illness and how they can self-help. But they also then would understand that in a certain circumstance where they think they may, I don't know, a respiratory patient may think that they've got an acute chest infection, they don't necessarily need to see that GP that they've got that close link to, but to know that that GP has built a plan and they support the additional roles staff or an ACP or a practice nurse that can prescribe to be able to provide that care. But the fact that that GP and the patient have been involved in that care plan gives that patient the trust in the care that they're receiving from an alternative clinician. So again, that does help with the demand on individual clinicians.
Thanks for that, Paul. At similar lines, are you seeing? I always like a war story. Are you seeing a real great example of where empowering the patient, informing the patient, working together with the patient is actually reducing pressures and demand on the practice?
Something that you'd see very commonly, the practices that are most engaged with the patients are the ones that benefit most from self-care messages. So it's something that obviously seeding that throughout the year is really important, and you reap the rewards of that later in the year when the pressure's on. But continue to engage in a way that works for your patients is incredibly important. So PPGs, whether you're doing that sort of in the real world with a group, or more commonly now, some of the stuff around sort of virtual groups. So you're hearing voices across the practice, and by doing that you develop a two-way dialogue, so that as well as receiving the message around understanding how your practice can best serve your patient population, patients can be more receptive to listening to messages around self-care and how best to access the service and when not to access the practice as well, who can be best serving patients sort of within the community. Just kind of on that as well, so that's kind of led to a discussion with the practice I'm working at the minute around accessing the practice effectively is that what practice I'm working with, looking at appointment slot lengths, particularly for this time of year. And so looking at where the senior GP for a more complex consultation, actually contrasting that with something that might be a fairly short acute appointment, and actually adjusting those time lengths, using some of the time that they bought back by using sort of efficient procedures, using some of the online systems and like that, buying a little bit of time within the practice so they can actually dedicate the more complex cases with a longer time slot and reduce that when it's something that's more likely to result in an acute or perhaps a referral elsewhere if it's an online consultation. And Callum, the chap, mentioned around using some of the techniques that we've forgotten sort of from pandemic times, and I think it is really important to revisit some of those things for patient populations that might find it a little bit trickier to access that, but with some support. And Selena's mentioned around sort of digital exclusion work, that lots of patients that perhaps traditionally practices might have assumed that wouldn't benefit from sort of technological solutions actually can make sort of full use of those. Most people have smartphones now between 70s, 80s that would perhaps 10, 15 years ago wouldn't have imagined. So we've got lots of options for dealing with things in a slightly better way, and doing in a way that can be effective and efficient for patients and for practice use.
Paul, just to tie down on that one little bit, time and again I hear digital, and time and again I see it's actually great. But there's often the pushback, and I never quite get a clear answer on it. What about those that aren't digitally capable and can't, I'm talking about the patients that can't? How do you make sure they don't fall through the cracks if you set up a digital?
I've just noticed Nana Tamuno's in the chat here. I didn't realise Nana was on this. So Nana runs a group of practices in Leicester, and they've done a fantastic piece of work down there, similar to some of the work that Selena's describing, where they did sort of en masse lessons for patients that did feel digitally excluded, and they spent some time with patients, and I hope they've continued to do that as well, because it was really effective, where they actually had groups of about 40 patients in the practice at a time, and actually taking them through using online systems, how to register, how to order medication, how to do a consultation, and just sort of stepping people through that so it can be sort of so it's not so frightening. And they got a really sort of good response for that, and it was a great piece of work. And I know Selena sort of picked up on that in a different way, but actually also having people that are kind of in reception that are feeling empowered to actually go sit down with a patient at the reception. I realise you can't always do that, but when you've got the capacity to actually spend a bit of time and take somebody through ordering medication in reception and making somebody feel that their time for you as a practice is important, so they don't have to visit the practice every time to put a prescription slip in. It can make a huge benefit and actually feel like they're being listened to as well as a patient. So and I realise not everybody can sort of access technological solution, but it's there for a lot of people, and sometimes it's just spending an extra sort of 10 minutes to get somebody there can be really beneficial for everyone.
Thank you for that, and thank you for those that are putting comments in. Please put your comments in. We are going to come to all of those in the next few minutes. Saj, are you seeing anything? Let's just stick on the digital theme. Anything that you've seen digital that you go, wow, that's made a difference?
I think there's a number of things, Darren, that since we've started to utilize technology a little bit more, we've seen real improvements in practices. But it's some of the little steps that we can take that really help. So, for example, it's understanding your demographics again. So those that are under 40, have we got their most up-to-date mobile numbers, emails, that we can really utilize those and just ping them out a message and get them registered quite quickly. And all of a sudden, that volume of demand can be managed elsewhere, right? That's a real quick, simple, easy step. Others, if you've got a university practice, you'll see that online consults are probably more utilized than walk-ins and telephone. But likewise, where you've got highly elderly, technophobe kind of population, or where English is a second language in majority of the patients, you'll see picking up the phone or walk-ins will probably be highly more relevant. So although we're trying to move towards a modern general practice where it's talking about use of digitization and proactive to reactive, some of it is we've got to get back to basics as well. A bit like Selena said, providing that kind of care that's right for the patients. And by understanding your demographics, it's really easy to then consider what are the options and what are the things that are going to work in those areas. So if you're in a highly deprived area, not everybody might have an iPhone or a tablet or something that they can utilize. So we still need to keep those options open and available. But where there is capacity and opportunity, we need to communicate that to the patients that this is available. And like Paul mentioned, in practices I've seen where they had iPads in their reception area, and they had somebody stand there to help patients come in and say, actually, you know what, you can utilize this, you can do this on your handset. Do you have a handset? Let me help you, talk you through, and let's do it together. And by doing that a number of times, 1 or 2 times, all of a sudden, slowly, it's not an overnight solution, but over time, what you see is you'll see a slow increase. And this is where digital and data understanding is really helpful, where you'll see a slowly increase of their digital online consultations go up, where they can understand some of that, manage some of that demand elsewhere, and hopefully reduces the phone calls and the walk-in. But I do want to put a caveat there, Darren, is sometimes by increasing your online consultations, if you don't manage them effectively, you'll see more phone calls coming through because the same patient will say it's not being dealt with in time, so I need to make a phone call now. So it's just the balance of making sure we think it through, we put the right processes in place to be able to manage that demand if we're trying to move it away.
Great. Paul, are you seeing anything? So there's this whole digital thing going on with the patients that helps. Is there anything digital in the background that the practice uses itself that you're seeing?
Yeah, I've seen a couple of things recently that there are tools out there that can make a huge difference. And there's some of the bread and butter stuff around long-term condition management, but using them to make sure that appointments are being used effectively. So there are a couple of tools out there, and they're easy to find when you're looking for those things. But 2 separate practices I'm working with at the moment that are both looking to do a lot of work around phlebotomy and nursing appointments, but on reconciling the LTC reviews, long-term condition review appointments. So when you've got ad hoc bloods being requested, using systems that flag up and identify this is an opportunity to do this next upcoming review and collect the bloods or the metrics that are needed for that. Some really amazing sort of piece of work that can do prospective work for LTC reviews that in kind of reconciling those things. They'll also help you with making sure patients are booked in for the right appointments with the right clinician. If you've got somebody who's got a sort of diabetes and respiratory, making sure they're seeing the nurse in the practice, they can actually do both those things at the same time, sort of reducing duplication and making sure that those things are. The one particular tool I looked at recently actually is a pharmacist-led tool that actually puts workload in place for putting people ahead of the review dates. So all those things are done prior to the review date becoming due, and you can just make sure that it might be done as a desktop review then, because the patient doesn't need to come in, because all the metrics have been done either by a phlebotomist or an HCA, and the nurse can call them up. And it's just so some of those things that are fairly new to me, actually. I don't think those have always been available, but it's there's a real opportunity to just help you do the right thing, which I think we all aim to do, but it's very difficult when you're under pressure this time of year to do that stuff. And actually, it's stuff that happens throughout the year, but if you just freeing that resource up from unnecessary duplication in appointments, it does help a great deal to be able to have those things available for patients that are when they need it with acute things as we see over the winter.
Thanks for that, Paul. I did promise it in the last few minutes I would come to the comments, and we've got a few people have been commenting. Nana, your last comment on that. You basically said that Saj described your cohorts across your 3 practices, and Paul had mentioned that education drive for patients towards digital. You've just put an astonishing statistic in there. You just mentioned the huge difference it's made. You've seen a 50% reduction on calls with over 19,000 of your 24,000 registered online and using the online pathway. That's the difference that some digital can make, quite clearly. And quite clearly, you've put some effort in that. And we've already discussed, it's not too late to deal with your inner pressures. Get on that now. You're going to see stuff. We've had comments from Callum and Sarah. Callum, you mentioned that the pandemic made us think different. I think, Paul, you alluded to a couple of things you've seen on that. Has anybody else seen anything? Selena, have you seen anything that you picked up in COVID, other than COVID? Have you seen anything during the pandemic that changed something in your practice that's you're going to keep?
Yeah, I mean, it does help you look at different modes of working, and it can create efficiencies within the system. You know, using clinical systems to be able to send messages, surveys, pre-appointment questionnaires out to patients that they can respond back to. Something as simple as having a code behind a message where a patient can decline a flu vaccine or a COVID vaccine, that then stops the admin time needed to chase that patient, to offer a further appointment. It's an instant decline, it's coded, it doesn't need the admin to input. Respiratory COPD appointments, to be able to send out a link that's got a pre-appointment questionnaire that then saves time at that appointment for the valuable clinician. They've got all the information there prior to the patient attending. They could even decide that they don't need the patient to attend surgery. That could be a telephone consultation because the patient's had no exacerbations in the last 12 months. So they could do a telephone consultation, or it may be that they think their inhaler technique needs reviewing and they do need to bring a patient in. So it's about being efficient, and gaining that pre-appointment information is vital.
Thanks for that. We're into the last 5 or so minutes now. So Stephen Walsh has just asked Nana, do you feel that patients are getting a better outcome as a result of that, getting them on the digital online pathway? Be interested to see if Nana, you're still on. If you could answer, that'd be really great. Are they getting greater access? What's the patients really think about that? But as we come into the last 4 minutes, as it is now, I'm just going to go to each of you and just ask you in sort of 30, 40 seconds, just to give me that one nugget that you would tell people about winter pressures and what they should be doing now. Saj, I'm going to start with you. 30, 40 seconds. What's that one nugget?
I think just looking at previous historical data, I think, and looking at and understanding your demographics, which most practices do, is just thinking about what do they predict some of the challenges. And some of those answers you've already got, but I think what's really important is trying to maybe plan and take out some of that time in your really busy schedules to do a bit of planning. I think that'll go a real long way in helping you manage some of the challenges going forward.
Thanks, Saj. Paul, same question to you.
Yeah, exactly what Saj just said. Take that work and actually have that meeting with the leaders in your practice across all the different departments to make sure you've got plans in place about how you're going to support each other, how you're going to talk to each other throughout winter, and how you're going to keep nimble and keep moving ahead, and sort of recognizing that you've got to stay agile to be able to cope. And so how are you going to support each other? Who's going to fill for each other? And who are you going to talk to outside of the community, patients and partner services, to make sure you understand what the pressures are on those people and how you can best help them to help themselves as well, to deliver care and to take care of themselves.
And Selena, your final nugget.
I think Paul's covered it really. 3 points I would make: engage with all your patient cohorts, find out what they want and whether that is doable and how you can support them. Communicate with your patients what you are actually putting in place. Something as simple as, we have ordered you your flu vaccine. Personalize the interventions that you've got with patients, but also support your staff. Be there, make sure you're underpinning your teams, because if you haven't got a team, you haven't got a GP practice.
Thank you, Selena. Saj, we wouldn't be able to bring these webinars without the support that we've got from the DCOT tool. Here's your 30 seconds, 1 minute. Tell us about DCOT and why that is going to help with winter pressures.
Cheers, Darren. So yeah, I mean, first of all, thank you all for joining us today. And as we discussed, we know understanding and preparing for winter pressures is crucial for effective practice management. So, and to help do that, our demand and capacity optimization tool can really help practices, 1, identify hidden patterns in their winter demand, 2, spot potential pinch points before they become issues, optimize resource allocation during peak periods, and make data-driven decisions for winter planning. And some of the concepts we touched on today, the tool enables us to really understand some of them in a bit more detail. So the principle behind the tool is to reveal those kind of unseen trends in your practices and your practice operations, and enabling you to better prepare for and manage seasonal pressures while maintaining quality of care. So if anybody wants any more detail about the information, about the tool, then please visit our website, demandandcapacity.com, or hopefully contact us following this, the QR code, and following this webinar for a demonstration.
Look at that. That's technology. The QR code is up there. Our time is up. It's been a great debate. I hope you found it useful. A big thank you to my team, to my fantastic panel, Saj, Paul and Selena. You've been great. You've been a great audience as well. Some fantastic comments. I hope we got round to them all. Please tell us about it to your friends. There's ways to look at this as a recording. Please do that. We're also looking for ideas for our next webinar. Please do get in touch. And if you want to be on a panel, get in touch about that as well. So once again, thank you to our panel. Thank you to producer Claire, who makes sure this all happens. And we hope to see you again. And please, on this Halloween, don't be scared of those winter pressures. Thanks for your time.